Welcome to our research brown bag, our last one of the semester. And I can't think of a topic that's more timely or important. And I can't think of any speakers that could be any more wonderful to come and talk to us about this. So we'll be talking about the changing landscape of abortion in the United States. And our speakers are two graduates of the epidemiology PhD program at UC Berkeley, and both people I love dearly and I appreciate so much for being willing to come talk to us. So our first speaker is Dr. Ruvani Jayaweera, and she's a research scientist at Ibis Reproductive Health. And then Dr. Gerdts, who's Vice President for Research at Ibis Reproductive Health. So thank you so much, Ruvani and Caitlin, for talking to us today.
Thanks, Jen. And hi, everyone. And like Jen said, unfortunately, this is an even more timely presentation on the changing landscape of abortion access in the United States. So myself, Ruvani Jayaweera, along with my colleague, Dr. Gerdts, I'm really grateful for the opportunity to speak with you all today. Before I dive in, I wanted to share a little bit about us both and where we work. We're both from Ibis Reproductive Health, which is a nonprofit research organization that has offices here in the Bay Area and Oakland, as well as in Massachusetts and Johannesburg, South Africa. And Ibis conducts clinical and social science research that seeks to advance sexual and reproductive autonomy, choices, and health worldwide. And we have active research projects all over the globe and really prioritize conducting research in close partnership with service providing organizations, whether it's clinics, community-based orgs, or feminist networks. I'm a research scientist at Ibis. Caitlin is the VP for research. We're both epidemiologists by training, like Jen mentioned, and graduates of the doctoral program at Berkeley. So it's really nice to be back with you all. And our objective for our talk today is to provide the School of Public Health community a brief overview of abortion as a public health issue, kind of talk through some of the impacts of abortion restrictions in the US broadly, as well as the impact of the current Supreme Court's case, Dobbs versus Jackson Women's Health, that will be officially decided on in the coming weeks, and conclude with an understanding of the role of public health research in abortion access. So to start us off, I want to ground us with the shared understanding of abortion as a human right. So international human rights law specifically recognizes and protects access to safe and legal abortion as essential to guaranteeing the full range of human rights, including the rights to life, health, equality, and non-discrimination, privacy, and bodily autonomy. And in the United States, Black women social justice leaders in 1994 created the framework of reproductive justice, which is firmly grounded in these human rights principles, and really sees abortion and reproductive health services as resources that everybody is entitled to, just like healthcare, education, housing, and food. And reproductive justice is a contemporary framework for activism and holds the following principles. 1, the right to not have a child. 2, the right to have a child, and 3, the right to parent children in safe and health environments. And abortion is a key component to ensuring that these 3 rights are met. Abortion is also a very common experience shared by many people around the globe. This graph is from a 2020 study from the Guttmacher Institute and the World Health Organization that sought to estimate the annual abortion incidence rate across different regions. Globally, the annual abortion rate is 64 abortions per 1,000 women of reproductive age, which roughly corresponds to about 73 million abortions each year. And I'll pass it to Caitlin to give an overview of what the abortion methods are.
Great, thanks, Ruvani. So abortions are extremely safe. Let's start with that. In a 2018 landmark report from the National Academy of Sciences called The Safety and Quality of Abortion Care in the United States, the National Academy examined decades of clinical, epidemiologic, and social science evidence to conclude that abortions that are provided in the United States are safe and effective. We talk a lot about abortion in many different contexts, but we don't really talk about what it is. So just to give us a little bit of grounding in what an abortion entails, both medical and instrumented methods are recommended at any gestation by the WHO, the American College of Obstetrics and Gynecology, and other professional bodies for abortion. The most appropriate method of or protocol for abortion differs by the duration of pregnancy. Based on a robust body of clinical evidence for pregnancies below 12 to 14 weeks, the recommended abortion methods are manual or electric vacuum aspiration, which is really a simple procedure using the suction of a syringe to remove the pregnancy tissue from the uterus. A thin tube is guided through the cervical opening into the uterus. The syringe is attached to the tube and used to remove the contents of the uterus. It takes less than 10 minutes. Medication abortion, also commonly referred to as the abortion pill or pills, can involve either one medication called misoprostol or two medications, misoprostol in combination with mifepristone. And by taking either one or two medications, it causes a process that is much like a miscarriage. Misoprostol is usually dissolved under the tongue and mifepristone is swallowed. Both regimens, one medication or two, are safe and highly effective. We'll give you some links to medication abortion protocols in the chat in case you're interested. Later in pregnancy, the recommended surgical method is dilatation and evacuation using essentially vacuum aspiration and forceps. Medications can also be safely used for abortion throughout pregnancy. I also just want to take a minute to say that it is true that for many reasons and in many contexts around the globe, these WHO recommended methods for abortion are not available or accessible. Throughout history, people have used a wide variety of herbs and medicinal plants to induce abortion, the safety and effectiveness of which have not been well documented in the literature, but certainly there are centuries of experiential evidence. And unsafe methods such as trauma to the abdomen, insertion of foreign objects into the vagina, etc. Can you pass to the next slide, Ruvani? Thank you. As public health professionals, it is critical that we situate abortion squarely within public health and, as Ruvani started us off, the reproductive justice framework. Here at Berkeley SPH, we articulate first and foremost the value that health is a right. We strive to reduce or eliminate inequity and injustice that affects the health and dignity of all people, especially those who are most vulnerable. Access to abortion is fundamental to individuals, couples and families, and communities' ability to obtain the highest possible level of health. It is imperative that abortion care, like all health care, is equitable, and that health care does not vary in quality based on the personal characteristics of whoever is seeking that care, such as their gender, their race, ethnicity, or socioeconomic status. Decades of clinical, epidemiologic, and public health research, much of it generated by colleagues at UCSF, has demonstrated that when access to abortion is denied or legally restricted, people are delayed in seeking care, elevating risk of morbidity and mortality as abortion is safer at any time in pregnancy than birth. And that people denied abortions experience greater economic hardship and insecurity as compared with those who receive wanted abortions. That they are more likely to maintain contact with a violent partner and thereby experience gender-based violence, that they're more likely to experience stigma, and that the financial well-being and development of children that abortion seekers already have is negatively impacted when their pregnant parent is denied an abortion. When people are forced to carry unintended pregnancies to term, they are also denied the right to decide whether, when, and how many children to have, and to have the information and means to do so, free of coercion, discrimination, and violence. Across contexts, we see again and again that those who are most marginalized face the greatest barriers to care, a reality that has only been exacerbated in the midst of this global pandemic. A public health strategy to achieve the highest standard of health for all must protect and advance access to abortion and reproductive justice. Ruvani, I'll pass it to you.
So the current state of abortion restrictions in the US are really a culmination of decades of increasing restrictions on abortion at the state level. Guttmacher described 2021 as the worst year on record in which the most abortion restrictions since Roe v. Wade passed. And these types of restrictions that are passed at the state level fall under three broad categories. One are abortion bans, which are bans on abortion based off a specific pregnancy duration, such as a 15-week ban or a 6-week ban. Restrictions on medication abortion, so explicitly prohibiting telehealth for medication abortion, placing restrictions on when in pregnancy medication abortion can be used, even though, as Caitlin said, they are safe and recommended for use throughout pregnancy. And restrictions that are targeted at forcing abortion clinics to close by passing restrictions such as requiring hallways in clinics to be a certain width or requiring providers to have admitting privileges at the nearest hospital. There's also bans such as waiting periods that force people to wait 24 or 48 hours between their first appointment and when they're ultimately able to obtain their abortion. Laws requiring people to have and view an ultrasound even when it's not medically necessary for abortion care. As well as laws forcing providers to read medically inaccurate information about the risks of abortion, with the ultimate goal of chipping away at access at the state level. And so the last few decades of public health research on abortion in the US has been really geared towards the courts and regulatory bodies. For example, there's been a lot of research documenting the impact of clinic closures on people's driving time to clinics, research on the long-term impacts of being denied an abortion, as Caitlin just described, research on whether different providers can dispense medication abortion, research on the impacts of denying health insurance coverage for abortion, research on telemedicine for abortion and its safety and effectiveness, just to name a few broad areas of research. And while there have been some wins in the past few years, so in 2016, Whole Women's Health versus Hellerstedt in Texas, and June Medical versus Rousseau in Louisiana in 2020, in both of these cases, the Supreme Court ruled that these state-level abortion restrictions pose an undue burden on people seeking abortions and were ruled unconstitutional under the precedent set by Roe and Casey. And these are two really great examples of the use of research and influencing policy. Both of these cases really heavily relied and cited public health research that documented the harms of these laws on people's access to abortion in their opinions. Unfortunately, the current makeup of the court seems poised to overturn the prior precedents. And so research documenting the harms and impacts on access can't really be used to inform any policy decisions if the overarching framework of constitutional protections for Roe are overturned. However, there is some bright spots in states that aren't hostile to abortion rights, such as in California. There have been actions to protect and affirm abortion access, such as overturning older pre-Roe abortion bans that are on the books, kind of anticipating an eventual overturn of Roe, providing state insurance coverage for abortion, allowing for telehealth and expanding the cadre of medical providers such as PAs or NPs who can provide medication abortion. And all of these laws have really relied on public health research in their drafting and passing. In California 3 years ago, just thanks to efforts from students here at Cal, California passed legislation to provide abortion pills on all public university campuses at no cost. And earlier this year, there was legislation passed to eliminate all out-of-pocket costs for abortion care in the state of California. And there's a slew of protective legislation that's been introduced, such as establishing funds for those traveling to California from other states and protections for providers and support people. However, the latest slew of abortion restrictions, such as the 6-week ban that was passed in Texas last year and a 6-week ban about to go into effect in Oklahoma, the Supreme Court has really allowed these to go into effect, even though they are not constitutional under the precedent set by Roe v. Wade. And I'll pass it back to Caitlin to talk about what's been happening in Texas and what we anticipate happening moving forward.
Thanks, Ruvani. So just to drill down into what it looks like when clinics close and when restrictive abortion laws are passed. On September 1st, 2021, Texas Senate Bill 8, which I'll refer to as SB 8, the most restrictive state-level abortion law in the United States, went into effect. The law bans abortion upon detection of embryonic cardiac activity, which can take place as early as 5 to 6 weeks after a person's last menstrual period, which is far before many people know that they are even pregnant. The law also permits anyone to sue abortion providers and others who help someone obtain an abortion in Texas after this stage of pregnancy. So while legal challenges to the law have continued in state and federal courts, SB 8 has remained in effect in large part because of some of the novel provisions in terms of who is implementing the law. There are no state level actors essentially to contest. Many of you may have seen the graph that is on the screen here in a recent New York Times article denoting the impact of SB 8 on Texans' access to abortion. The article was titled, "Most Women Denied Abortions by Texas Law Got Them Another Way." But the reality behind this graph is far more complicated. First, research from the University of Texas at Austin documented that in the month following implementation of SB 8, the number of abortions that happened in Texas fell by half when compared to the same month in 2020. And it's important to note that even while many Texans may have gotten abortions, there is still a dramatic decline in abortions from March of 2021, which you can see denoted by the dotted line. I also just want to call your attention to a few things in this graph. It's important to remember that just because people requested abortions or abortion pills online, sort of in that middle purple area, doesn't mean that they were successful in obtaining the pills or that that the abortions were completed. And that while many folks did travel out of state, travel is simply not an option for a lot of people, those who have childcare responsibilities or elder care responsibilities, adolescents who can't leave home or tell their parents, folks who have jobs that they can't miss multiple days of work for. Not to mention that among those who traveled from Texas, most went to Oklahoma. And as Ruvani just mentioned, there is now an SB 8 style law that is about to go into effect, virtually eliminating abortion provision in the state of Oklahoma. Critically, though, I also want to say that this graph minimizes the work that went into getting people abortions in Texas or elsewhere. That abortion funds, people in abortion clinics, those working at the grassroots level just to ensure people get to care is simply an unsustainable amount of time, effort, resources, coordination, and money that should not have to be expended for access to what is, as we have talked about, a simple, very common medical procedure. Next slide. So when we signed up to give a brown bag today, we did not quite realize how timely this information would be. But yesterday, as many of you may know, there was a report that a draft opinion for the Dobson v. Jackson Women's Health Organization case that the Supreme Court heard in this session is circulating, and the draft appears to overturn both Roe versus Wade and Planned Parenthood versus Casey. To be clear, this is a leaked draft opinion, not a final order of the court. And until we actually see an official final opinion, it can continue to change and evolve. It's also important that everyone knows and continues to say abortion is still legal in the United States. In Dobson v. Jackson, just to back up and give everybody a little grounding for what this case is, the Supreme Court is considering whether all bans on abortion before viability are unconstitutional. Mississippi has asked the Supreme Court not only to uphold its 15-week abortion ban, but also explicitly to overturn Roe versus Wade and rule that there is no right to abortion protected by the US Constitution. We anticipate that the final decision will be issued before the end of June. With the new information from the leaked draft opinion, it is most likely that the Supreme Court will allow Mississippi to enforce its harmful 15-week ban on abortion and open the door for state legislatures eager to further restrict and ban abortion. Now, there are a number of states that have what we call trigger bans in effect, which would immediately ban abortion upon a decision that overturns Roe. And as you can see from this map, there are up to 26 states that are anticipated to ban abortion immediately or quite soon after a decision that would overturn Roe. It is important to say in the context of public health that abortion bans like Mississippi's are a part of the intertwined systems of oppression that deny Black, Indigenous, and other people of color access to their rights and are rooted in anti-Black racism, white supremacy, and other forms of discrimination. We have to situate ourselves in the multiple intersecting systems of oppression so that we can understand the true public health impact of abortion bans. Ruvani, I'll pass it to you.
So as Caitlin mentioned, sometime early this summer, the US is poised to join the other countries here in red, which are countries globally where abortion is prohibited by law. Red being the most restrictive country context, yellow are countries where there's exceptions to preserve the health of the pregnant person, and blue are places where abortion is available on request without any justification or reason. So globally, these restrictions on abortion are not new. And while we know restrictions do prevent many people from obtaining an abortion within clinics, it doesn't prevent abortions from happening. Some proportion of the abortions that occur in restrictive settings are considered to be unsafe using some of the methods that Caitlin described earlier, but a growing proportion of all abortions globally are self-managed medication abortions. And I just want to reemphasize that self-managed abortion as a concept is not new. People have been self-managing their abortion for thousands and thousands of years. For as long as people were getting pregnant, they've been self-managing their abortion. And it was pregnant people in Brazil in the late 80s who first discovered the use of misoprostol, one of the WHO recommended medication drugs, as an effective abortion medication. So really the roots of medication abortion itself are really rooted in the concepts of autonomy and self-managed abortion. And so many of the countries in red, there are community-based organizations and activist networks, which are often called accompaniment groups or safe abortion hotlines, that provide people with information and support on how to safely and effectively self-manage their abortion using these WHO recommended medications Caitlin described earlier. And so even in places where abortion is not available legally from clinics, the medications themselves are often obtained from people with the help of these accompaniment networks. They're obtained from pharmacies over the counter, especially as misoprostol has many other indications, such as treatment for gastric ulcers, arthritis, postpartum hemorrhage, that make them available at pharmacies and also in on the black market. And very excitingly, earlier in March, the WHO recently updated their abortion technical guidance to fully recognize the role of the individual in their own abortion process and fully recommended self-managed medication abortion using either mifepristone in combination with misoprostol or misoprostol alone as a recommended model of abortion care. And this change in the guidelines is really a monumental shift in global abortion policy, recognizing the individual as their own abortion provider, and is largely due to the efforts of these activist networks and their partnership with researchers to document the outcomes of those that they support. At Ibis, I've had the privilege of working on the SAFE study, which was a prospective observational study conducted in partnership with safe abortion hotlines and accompaniment groups in Nigeria, Argentina, and Indonesia. And in our study of over 1,000 callers to these accompaniment groups, we found that self-managed medication abortion was highly effective, over 95% for both regimens, and safe with very low levels of any type of potential signs of complications, and non-inferior to the effectiveness of medication abortion when administered in a clinical setting. And this research, along with other research by some of our colleagues on the effectiveness of self-managed abortion, as well as the decades of experiential evidence from our activist and accompaniment group colleagues, really informed this shift in the WHO guidelines to recommend it as a method. And given where things are headed in the US, we would expect that the need for self-managed medication abortion may be the only option for effective abortions in restrictive states, especially for those who are unable to travel. I think it's really important for us to know as public health professionals that when people have access to medications and information on how to take them, self-managed abortion is safe and effective. And in the US, there are already activist and community networks that have been providing people with information and support even before this decision and before the rise in abortion restrictions, because there have always been people who have preferred self-managed medication abortions to clinic-based care. However, the need for these support networks and this type of information will only rise in the coming months. And while it's important to note that there are no medical risks to self-managed medication abortion, there are legal risks, particularly in states that are hostile to abortion rights, where people will maybe be prosecuted for self-managing their abortion or supporting people in self-management. And particularly for communities and people who are already over-policed, are those who are more likely to be targeted by these restrictive laws. And there's a lot of work being done by existing organizations to support people in self-managing that we'll share in the chat, as well as protect them from prosecution. And I'll pass it back to Caitlin to close this out.
Thanks, Ruvani. So what do we do? What's next? I think as we, as a public health community, come together to think about much of what we've talked about today, it can be easy to despair and to feel overwhelmed by the violation of public health and human rights principles that this moment in our country's history represents. It can feel paralyzing to think about the harms, both physical and legal, that we know will be perpetrated and that already exist. But I think that's a place for us to start. Though we broadly do understand what many of the harms will be, one of the roles of public health researchers must be to document the impact of restrictive abortion laws broadly, and to continue unflinchingly to observe so that the harms do not become invisible. It's also our role to be responsive, to listen to communities who know what resources they need and ways in which research and evidence can help to advance access. Ruvani talked a bit about some of the innovative interventions that our colleagues all around the world who have experience working under more restrictive laws than we may even see here have been able to implement in order to provide access to high quality, person-centered abortion care, even in restrictive legal settings. And it's our job as public health researchers to evaluate those interventions, to understand what works and what doesn't work, and what can help to make access and quality easier and better, even amidst continuing challenges. I think finally, when I think about, or when I take a step back to think about what the future looks like, certainly, as Ruvani has said, the public health research strategy that for years generated evidence sort of in the service of contributing to court decisions and to policy decisions may not be the specific strategy for the next 20 to 40 years. But because we now know and have a better understanding of the many intersecting oppressions, the many ways in which abortion touches on other public health, social justice, and reproductive justice issues, as public health researchers, we can contribute to the efforts to lay the groundwork for a more equitable future of not only abortion access, but access to all of the things that individuals need to be able to choose when, whether, and how to parent, and to do so in communities that are supportive and free from violence. I do think that that is something hopeful to hold on to, and that we as a public health community have a responsibility to situate ourselves in the fight for abortion access and to ensure that even with the restrictions that we will inevitably see, people still are able to access evidence-based, high-quality abortion care and to lay the groundwork for a better future. I think we'll share a few resources now and then open it up for questions.
Oh, thank you so much, Ruvani and Caitlin, for that really amazing overview, and so timely and important for us all to be thinking about these important topics and what we can do as a community. So thank you very much. If people want to post questions in the chat, or you can raise your hand and unmute and ask a question. We will be sharing the slides and also the resources and the recording with everyone today. Any questions? Jen has her hand up. Jen, do you have a question?
Hi there. Thank you so much for your really sort of broad and comprehensive presentation. I was hoping one of you could speak a little bit more about if you're aware of activities that are happening to try to support those folks in states where it's anticipated that restrictions are going to be much more, I don't know, even more, that restrictions are going to be tighter than they already are, and or that they may have to go further than they would have previously to seek care if they're going to go out of state. Sort of, what can, your average Bay Area resident do to be supportive of, whether it's donating or whether it's organizing or just sort of practically. I think I'm feeling a little bit like helpless in terms of like what actions could be taken. So if you have thoughts about that, I think that would make me feel like I have ways to engage.
Yeah. Thanks, Jen. Sorry, I'll start and Ruvani jump in. I mean, certainly, and we're happy to share a list of resources. Many of the resources on this page are great sources for both information and places where you can find organizations who are either close to the ground. I can see somebody put a link to the Lilith Fund, which is a Texas-based fund. The National Network of Abortion Funds coordinates many of the local and regional abortion funds. So, fund the funds is one way to really help ensure that people who do have the ability to travel can still get to care. I think it's also really important to think about, and we don't have it here, but we can put a link in the chat, the independent abortion clinics, who are most of the folks who support later abortion provision. And as we know, where abortions are restricted, people are delayed in seeking care. So we will inevitably see more people seeking abortions later in pregnancy. And there aren't that many clinics across the country that provide that kind of care. So the Abortion Care Network is the network of independent abortion clinics, and they are just going to be absolutely critical to maintaining access to the abortions that people need across the country. Something like Yuki, which is here on the slide, is a comprehensive sexual and reproductive health app that has information about all kinds of resources, as well as protocols for potential self-managing abortion and just information that people might need. And it has been designed, it was released by our colleagues at Women Help Women. It's really been designed to protect people's privacy and security. It does not store any back-end data, and so people can use it and ensure that there's sort of less of a digital footprint than many of the sort of femtech apps that we think about out there in the world, and is a really good source of information, especially for people in states that might be restricted, just sort of a common source for information. And I think from the legal perspective, people who are considering their options and trying to figure out what to do, the Repro Legal Helpline, which is situated at If When How, but came out of the SIA legal team, which was actually founded at at the law school here in Berkeley is just a phenomenal resource, and many, many questions can be answered there. And then I think, reproductive justice organizations across the country who are really working to build towards a post-Roe future that is more equitable and more founded in a reproductive justice framework, not just a framework of choice, is also a really great way to sort of think about, dedicate resources and support efforts.
I would just to affirm that practically, I think donating to independent clinics and abortion funds, and funds definitely in states that are hostile to abortion rights and where people will have to be traveling out of clinics, but also funds that are located in states that are likely to be receiving a lot of people who are traveling, and funds will coordinate with each other to make sure that people kind of have both the money that they need and resources to travel, but also some of the practical support like a place to stay, coordinating logistics around housing and timing of their clinic appointments and all those pieces. So I think, and the National Network of Abortion Funds is doing their annual fundraiser right now. So it's actually a great opportunity to get involved in that and to spread the word to folks that you know. And then also as public health researchers, I think being armed with the facts and the public health implications of what the impacts these laws have on people's lives, as well as I think making sure that the ways that we're talking about abortion and abortion access are aligned with what folks on the ground have said are their needs. So I think even basic things about like not using coat hanger imagery when describing kind of what a post-Roe future looks like, especially since we know that self-managed abortion, there are safe methods of self-managed abortion. A post-Roe future will largely be focused on helping people get access to information about the self-managed methods that do exist. And we can share, I think, messaging guidance that have been developed by some of our colleagues that might be helpful for you all as you in the future.
I think the one other thing that I will say, just in line with that suggestion, is as public health professionals, ensuring that we're talking about abortion as a public health issue, as a part of normal healthcare, is the work to normalize what abortion means in people's lives and why it's critical. And I think we often, as epidemiologists who work in abortion, I think Ruvani and I have both heard critiques and criticisms of abortion as more of a political topic than an epidemiologic one, but we know that that is not true. And the more that we as a public health community can situate it squarely where it belongs, I think we can really make an impact on normalization and thinking about abortion as a part of standard reproductive health care, which it needs to be.
Thank you so much. Steph, did you have a question?
But I would love to wait if there's students who have questions first.
Okay.
But not seeing any. I'm really interested in your views on some of the political aspects. There was a really good on KQED forum this morning, a discussion about the history of the anti-abortion movement, starting with white male OBGYNs who were trying to take business away from women who were midwives at sort of the start of the allopathic movement, and the fact that post-Civil War, this was married to a white supremacy argument that white women needed to spread their loins east, west, north, and south to essentially, create more white people. I'm fascinated by what that arc translates into today, because as you both pointed out so well, these restrictions fall most disproportionately on women of color in restrictive states who are unable to, for whatever reason, to travel to access abortion services in states where it's still available. And related to that, sort of given the early history, 40 years ago, the AMA and the American Nursing Association were permissive but not supportive. I think they both come out in recent weeks in strong opposition to what appears to be about to come out from the Supreme Court. And I'm wondering whether you think that medical professionals can be, in an organized way, stronger allies. So curious on your take on both of those things.
Thanks for that question and situating us in the history. I'm going to put a link in the chat to a recent op-ed in the New York Times by our longtime colleague and collaborator, Monica Simpson. And I cannot recommend more highly that everyone read this piece and really understand the links of the anti-abortion movement to white supremacy and histories of racism in this country. It is inextricably linked, and as we see, it is, I hope, not lost on anyone that in Mississippi, a state where a great majority, or maybe not a great majority, but a large proportion of the population is Black, that this is a state effort to, control Black women's bodies, and that this is the case that will be decided at the Supreme Court, and will, it looks like, ultimately overturn Roe. I think intertwining our public health framework and the reproductive justice framework is absolutely necessary for us to be able to build a better future. So I think I just really encourage everyone to do your research on reproductive justice and really think about the two collectively as we're thinking about what change looks like for the future. Your question about medical professionals stuff is really interesting because, you're certainly correct that most of the medical establishments have come out in opposition to abortion restrictions. There are many statements that we will see from medical professionals. One of the impacts that we haven't talked about these abortion restrictions at the state level is that training for medical professionals will not exist in states where abortion is restricted or illegal. And that is the case in many states already, but thinking about the pipeline of abortion providers, it really is going to have an impact on who can be trained and where. But I think there's also a way that medical professionals, and especially Ruvani talked a bit about some of the efforts in California and other states to really broaden the cadres of healthcare providers who are able to provide abortions in states with more expansive laws. And certainly, thinking about medication abortion or manual vacuum aspiration abortion, these are not complicated procedures. Family medicine docs are easily able to prescribe and provide access, especially to abortion, below 12 to 14 weeks. And that's something where you could see the potential for a mobilization of more sort of broad-based cadres of medical professionals. And then also just to remember that the WHO has fully recognized individuals themselves as safe providers of their own medication abortions. And so as we think to the future and think about efforts to make abortion pills available at pharmacies or over the counter, and thinking about sort of a broad umbrella of services where people can access abortion how and where they want. Certainly, there will always be some proportion of people who would want to go to a clinic if everything was available, and some proportion of people who would never want to and would want to manage the entire process themselves. And having the WHO guidelines as the gold standard for what that kind of umbrella of care could look like, I think we can also think about cementing the evidence and really laying the groundwork, especially in states where access continues to be available, for a better, broader based access, probably quite far down the line, but hopefully for everyone eventually.
And I just want to add, and just thank you for uplifting kind of how restrictions on abortion are really rooted in white supremacy, and also to acknowledge that abortion restrictions aren't in a vacuum. These are the same states and same legislatures that are passing restrictions on stripping voting rights protections, that are passing laws that are criminalizing trans and non-binary people, particularly young people, and eliminating access to gender-affirming healthcare. And it's kind of a package of laws and restrictions, all kind of focused on preventing people from deciding on their own healthcare, childbearing, family size, and the way that they live their lives. To the second point, to add on about the role of medical providers and professionals, I think from a criminalization standpoint, people who have sought care post a self-managed abortion, or even seeking care post a miscarriage, have been reported by providers in the ER or medical care providers, medical professionals. And it is not within their scope to need to report people to the police or criminalize them for their pregnancy outcomes. And I think that's a place where is really ripe for additional advocacy and statements and guidance from within medical communities to not report people who are coming in with miscarriage or who have been suspected of self-managing an abortion, and that being a really key place for intervention.
Thank you. Eliza had a comment I'm going to read on the point of normalizing abortion. I think it would be really great if more professors and classes at Berkeley talk about abortion in their curriculum or use it as examples. As a student here, I've only had about two classes talk about abortion in summer because I brought it up since it's my research area of interest. So thank you, Eliza, for that. And also she has a question. I may have missed if this was mentioned, but also emergency room physicians being trained in abortion care will be key as people who are self-managing their abortions, though it can be super safe, as said, may run into complications and go to ERs.
Yeah, and to that point, Ruvani has addressed some of it already, but I do think there's also, really important information out there about for folks who are self-managing abortions, knowing their own rights, knowing that they don't have to disclose that they have self-managed. Self-managed abortion is indistinguishable from a miscarriage. And if you don't feel comfortable talking to a healthcare professional about what you've done, you do not under any circumstances need to. And then on the flip side, despite the fact that in many of these states where abortion restrictions will be in place, training ER docs on actual abortion provision will be challenging. I think training them on the kind of messaging and understanding that first do no harm is also about, not reporting your patients to authorities and making sure that you are actually protecting their health. There is quite a bit of work being done from If, When, How and other legal colleagues trying to intersect with some of the clinicians in urgent care and ER settings to make sure that they have that information, but will be a critical effort.
Great, thank you. Coco had a question earlier. Is the regimen in the SAFE study source? But I'm not sure what she meant by that.
The regimen is in the SAFE study in there, but we'll send a link to a more accessible link.
Yep.
Thank you. Great. All right, any other questions? This has been super, super informative and really, really timely. I really appreciate everyone's time today and all the links. We'll share out the links and the resources that were shared today.
Thank you, Caitlin and Ruvani.
All right, thank you so much. I really appreciate your
Thank
time
you
today.
all.
Everybody.
Thanks for having us.
Have a good day, everyone. Thank you so much. Bye.
Bye.